So, we begin with imaging of the central nervous system. Now, there are relative advantages of MRI over CT, and they range from minimal to substantial. Now, the choice of the imaging should be, it depends on the severity of the symptoms, the urgency and probability of underlying disease vary and are part of vagaries of medicine. CT, the cost is definitely lesser, and CT is quick, reasonable diagnostic quality and can be used in uncooperative patients. Now, stroke is one of the most common indications while neuroimaging is done. While imaging, you need to know that the goal is rapid and accurate assessment of the cause. You might need to know why the stroke has happened. Is it because of an embolic episode? Is it because of an aneurysm? Is it because of a tumor? And separate patients with hemorrhage and other non-ischemic causes. Since TPA, or the recombinant tissue plasminogen activator, is effective in treatment for infarct in absence of hemorrhage, provided administered within 3 hours of onset. So, what is the role of CT in stroke? It rules out hemorrhage, rapid, it's quite fast and may take only 4.75 seconds. It's widely available, low cost, and can now perform perfusion studies. What are the drawbacks of CT? It will not detect an infarct in less than 3 hours, limited potential for brainstem, cerebellum, and small infarcts deep within the cerebellar. What is the role of CT? It helps in rule out hemorrhage. It's quite fast. It's widely available, low in cost, and can now perform perfusion studies. Drawbacks, these include that CT cannot pick up a stroke which is less than 3 to 4 hours, for which diffusion weighted imaging is extremely sensitive. So limited potential for brainstem, cerebellum, and small infarcts deep within the cerebral hemispheres. So what are the advantages of MR? Diffusion weighted imaging is extremely sensitive and can pick up strokes within 30 minutes. Perfusion studies will tell you what is the area of the penumbra. This penumbra is one region around the infarcted tissue, which is potentially salvageable. So in case you give RTPA, that tissue can be salvaged. Lacunar lesions in deep cerebral hemisphere, brainstem, and cerebellum are easily picked up. So what is the drawbacks? They are basically the time factor. May be difficult to monitor patient in the MR suite, and the cost. What happens is in strokes, certain patients, they become disoriented, they might become rowdy, and they might not comply, and they keep on moving. Hence, MR would be extremely difficult in such patients. So let me tell you, this was a patient which had presented to us within 2 hours of the stroke. So this was a CT which was done, which is unremarkable or normal, and this is a diffusion weighted imaging of the same patient, which actually shows areas of restricted diffusion in the left frontoparietal cortex, so which was actually suggestive of an acute non-hemorrhagic infarct. Another patient which had presented with a thalamic bleed. So this is a T1 weighted image showing the bleed within the left thalamus. This is a FLAIR image, and this is a GRE image, and this shows the bleed very well. So one advantage of GRE, or the gradient images, it's excellent in picking up small quantities of blood or even calcium. However, it is extremely difficult to differentiate between calcium and blood on MR. So another sequence that we use at times if we are suspecting a venous infarct, or you want to rule out a thrombus within the venous sinuses. This is known as MR Venography. Now, this study may be done with or without the use of intravenous contrast. So over here in this patient, what we are seeing is the superior sagittal sinus, the transverse sinuses, the sigmoid sinuses, and the IJVs. So this is how it is. Talking about aneurysms and arteriovenous malformations. Aneurysms may present with subarachnoid hemorrhage and arteriovenous malformations with parenchymal bleed and or subarachnoid hemorrhage. So if CT is the modality of choice if the presentation is with the bleed. CT angiography is good to identify aneurysms in presence of a bleed. MR is good to identify arteriovenous malformations in presence of bleed. So in subarachnoid hemorrhage, CT may be performed before lumbar puncture, and then one may directly go in for an angiography. Now these are two cases, where this is the normal parenchyma, and over here you see a lot of flow voids and a lot of gradient over here, blooming over here. So this is basically our arterial AV malformation. So this is over here, you see a lot of vessels over here. This is your MR angiography, and this is how an MR angiography will help you evaluate the arteriovenous malformation. The next step, obviously, after this would be a DSA, a digital subtraction angiography, which will need embolization to take care of the arteriovenous malformation. Now these images, what I'm showing you over here, these are basically MR angiography images, which obviously they do not require any injection of contrast. So these are beautiful images that you can see over here of the vertebral arteries. This is your basilar artery, your ICA, your MCA, and these are anterior cerebral arteries. This was one patient where, over here, when we performed the MR angiography through the neck vessels, we saw a small aneurysm through here, but it was a non-thrombosed aneurysm. So that's, it shows us that it's a fusiform aneurysm. Again, like I said, the next choice after you pick up a lesion, digital subtraction angiography is the modality of choice for evaluation of arteriovenous malformations. Coming to brain tumors, calcification is best seen on CT. MRI with contrast is a modality of choice. Now there are a lot of advanced MR imaging methods for evaluation of the tumors, which would include your MR spectroscopy, MR perfusion, and diffusion tensor imaging. So MR spectroscopy will tell you about the metabolites within the mass within the brain, whether it has high lipids or lactate or alanine. Or MR perfusion will tell you whether what is the blood supply to the lesion. Is it a hyperperfused, which has high vascular supply, or is it hypoperfused? So this is a CT. This is imaging which shows a glioma in the left frontal region. This is how it looks, and after giving contrast, it enhances so much. There's another patient over here which shows a mass in the right parietal region, and so on. MRI, again, this is another a patient with glioblastoma multiforme. This is a lesion over here in the left temporal lobe. This is a coronal image, and these are the post-contrast images showing a pattern of enhancement. This is a patient with meningioma. So meningiomas are known to be extraaxial lesions, and over here it shows brilliant enhancement on the post-contrast study. So apart from looking at the meningioma, we're not only interested in looking at the meningioma, we want to see what is happening to the surrounding structures. Is it encasing the left MCA? Is it encasing the optic nerve and the chiasma? Or is it causing any pressure changes like hydrocephalus? So all this information would be required by the surgeon, because this will determine the next step for the treatment. Again, this is a patient who had presented with right-sided tinnitus. What we see over here on CT initially is this widening of the internal auditory canal compared to the left side, and this is how it shows increased enhancement on the post-contrast image. And this is the MRI of the same patient, and this is what it turned out to be, a cerebellopontine angle schwannoma. Once again, pituitary macroadenomas. MRI is a modality of choice. A pituitary macroadenoma is less than 10 mm in size, and a pituitary macroadenoma is more than 10 mm in size. So if you're suspecting a pituitary macroadenoma, you need to do a dynamic MRI of the pituitary gland with contrast. So this is how it is. Now, in acute cerebral trauma, let me tell you, CT is the modality of choice because CT is fast. It is extremely good for evaluating calvarial injuries, facial injuries, osseous orbital injuries, and a neurosurgeon would like to see that, because if there's a fracture, it needs to be fixed. MR will help in evaluating diffuse axonal injuries. Now these diffuse axonal injuries are particular areas in brain which present as microbleeds. So over here what you see is it's a fracture of the right parietal bone. Over here another patient showing an extraaxial collection, which is a hematoma. Similar cases over here, extraaxial collection, which is subdural hemorrhage. Same thing, another patient with subdural hemorrhage with a mass effect. There's a midline shift to the left side, and there's dilatation of the lateral ventricle. White matter disorders. In white matter disorders, just like tumors, MRI is a modality of choice. So, multiple sclerosis. This is typical, lesions perpendicular to the wall of the lateral ventricle, which are known as Dawson's fingers. Kernicterus, these are abnormalities in bilateral basal ganglia. Over here, this was a child with high bilirubin count on the 3rd month after birth. So this you have to know what are the causes of abnormalities in bilateral basal ganglia. Leigh's disease, another metabolic disorder. This is your typical abnormality, T2 hyperintensity within the putamen, and this is how a graph from the MR spectroscopy looks like. This is telling you exactly what are the various metabolites which might help you in determining what is the sort of disease process going on. This is your typical textbook tuberculous meningitis. When you do a CT, CT will, a plain CT, if you're suspecting tuberculous meningitis, it is used to see what is a meningitis doing to the brain. What are the complications? Is there hydrocephalus? Or is there an infarct? Or are there any granulomas? When you do a post-contrast CT or post-contrast MR, what you'll typically find is there's enhancement of the meninges in the basal cisterns, and you might even find granulomas within the parenchyma. These granulomas may either be seen as ring-enhancing lesions, and they might even mimic tumors. This was a patient with a congenital heart disease, and this was actually turned out to be a cerebral abscess. Again, this is an adult patient, which I talked about typical ring-enhancing lesions over here. This is a mixed type of pattern, but then these ultimately turned out to be tuberculomas. Neurocystic sarcosis, another granuloma, which is frequently a cause of seizures or epilepsy within the patients. So when a patient with epilepsy comes to you, the MRI should be the modality of choice, because MRI will determine what are the causes of epilepsy. Either is it mesial temporal sclerosis, is it malformation of cortical development, is there any sort of infection, is there a tuberculoma, is there or is there neurocystic sarcosis, and a host of other lesions which might be responsible for the convulsions. This is another patient with herpes encephalitis. Over here, this is a flare image, and this is a gradient image. What I'm trying to say is, look at the flare image. Typically, this is a T2 weighted image with suppression of the CSF. That's why these white matter lesions stand out over here. It's more easier to appreciate. And in herpes encephalitis, we take a gradient image because we want to rule out whether there's hemorrhage within the area, within the involved area or not. Same patient, see, this is a T2 weighted image. We can see the lesion. We can barely make it out whether that this area is abnormal. But once we give contrast, our level of confidence increases that this is actually the area involved. Obviously, after the MRI, the next thing to do would be a lumbar puncture. The same patient underwent a radionucleotide scan, and this area shows involved with herpes encephalitis. It shows hypometabolism. So while evaluating the brain, there are certain imaging modalities which are preferred. So there's a stroke, in which MRI is a modality of choice. MRI angiography or venography may be performed. CT is good at identifying subarachnoid hemorrhage. Transient ischemic attacks, MRI to rule out an acute infarct. A carotid Doppler may be performed to rule out a carotid plaque. Arteriovenous malformations, again, like I said, CT angiography, MRI angiography, or digital substraction angiography may be done. Cerebral aneurysms, CT angiography followed by DSA. DSA will be help will help in identifying the aneurysm and probably coiling the aneurysm. Again, neoplasms, MRI is a modality of choice. Infections, a combination either CT or MRI, and PET for problem solving. Trauma, CT is a modality of choice. White matter disorders and epilepsy, MRI is a modality of choice. When dementia is considered, MRI may be done. MRI, then probably CT if at all it is required, and PET for problem solving issues. Hypoxic ischemic injury in pediatrics. Neonates, MRI may be performed, but ultrasound is extremely good to detect subependymal hemorrhage. Now, miscellaneous topics which I would be covering would include, your neck, head and neck lesions. This is typically your thyroid. This is typically your thyroid gland. This is your right lobe. This is your left lobe, and this is your isthmus. And this is your trachea that the thyroid is overlapping. This, let me tell you, for identifying and evaluation of thyroid nodules and the salivary glands, ultrasound is a modality of choice. This is another patient with a large multinodular goiter heterogeneous appearance. This is a CT appearance. This is another patient with a pleomorphic adenoma of the parotid gland. This is an MRI appearance. This patient had a well-defined solid appearing lesion within the ultrasound. CA for head and neck malignancies like the oral cancer, there's a buccal mucosa cancer, the buccal mucosa, and this is a supraglottic cancer. CT is definitely preferred over ultrasound for local evaluation or local staging. Paranasal sinuses, X-rays followed by either CT. MRI is rarely used unless you're suspecting a malignancy or you want to see if there's any intracranial extension of any particular disease process. Again, for eyes, ultrasound is excellent for evaluating retinal detachment. This is your retina, and these are these exudates below the retina. This is another patient with retinoblastoma. This is a lobulated lesion which is seen on ultrasound. So this takes care of your evaluation. So, taking a recap, when you're considering evaluating oral and other head and neck neoplasm, CT neck should be done for oral and buccal carcinoma. MRI may be done for carcinoma of the tongue. Barium studies are good for pharyngeal masses, larynx, CT neck. MRI may be performed to look for cartilage involvement in CA larynx. Salivary glands, like I said, ultrasound is an excellent modality. CT is performed for further characterization of the masses. Thyroid disorders, ultrasound is a modality of choice. And of course, like we've discussed before, radionucleotide studies will help you in evaluating whether there is an ectopic tissue or not, or whether post-operative is there any residual tissue which is there or not. Paranasal sinuses, X-rays used to be done initially, even they're not done today, but actually CT is a modality of choice. Orbit, ultrasound is excellent for evaluation of the eye globe. MRI is used for evaluation of the orbital soft tissue masses and the retroorbital optic nerve. For temporomandibular joint, either your OPG or your MRI may be done. So with this, I conclude my talk, and thank you very much.